20 years. Been gone for 4 years this month. But I'm here to talk to you. I know, can you believe 4 years? Yeah, I know. And Tyler's 17 and driving and starting college classes. So it's amazing how time flies. But part of my conversation today is that we are starting to collaborate more with Catawba and having these end-of-life babies, comfort care only deliveries here at the hospital. So we kind of got together and said, let's provide some education and help you guys understand where these families are and what's happening behind the scenes before they come and deliver. Now, as you know, some of them come in and deliver and we've never met them. Doesn't mean we can't provide these services because Dr. Hada is the hospice doctor and she is on staff. So these babies do not have to go to the NICU. They don't have to be under Dr. Berry's services. So these are things that labor and delivery and newborn nursery can provide. The one thing that we have to remember is goals and care conversations have already happened. So as much as possible, we're getting that do not resuscitate. We're talking to the parents of what end of life means. That means no aggressive treatment. That means we're going to have meds on board to make them comfortable if they're struggling to breathe, if they're having some agitation. And then also, we can just make them comfortable and they can bond and hold their babies until they do pass away. And we're also getting consents from the family, okay? So all of those conversations have been had when they come into this hospital, 99% of the time. Now we had one, it was down to the wire that we finally got that do not resuscitate in place. Now there are going to be some where we never get there. And if we don't get there, and I know that it is something this hospital cannot handle, I'm going to advocate for them to deliver somewhere else. Okay? Because if they need surgery or they're going to need intubation or something like that, that I know is going to turn into a terrible mess here, I'm going to do everything that I can, talking with the team and saying, hey, we need to promote a delivery somewhere else. But then also, like Christian Green and his mom that delivered here, I brought them here from Shelby. They had a phenomenal experience, and they are still talking about it. And that also has helped our foundation and our program because we've had a lot of donations come in because of their experience that they never could have got anywhere else. And so that's a lot of information coming out about Catawba Valley Medical Center and also our program. So kudos because it was phenomenal. So we've come up with conditional orders that were up there.
I'm
No.
on your PowerPoint too.
No, that's okay. I do have it here. And they have the PowerPoint for y'all to print out as well.
I can pull it up. I'll leave that up for you.
So we've made it very easy on the meds and stuff. Also, when we're looking at it, so what we're going to start off with is vital signs are every 2 hours, okay? If the parents are okay with it. If you want to go in and say, it's time for us to check the vital signs, are you okay with that? If mom and dad say no, then no, don't do it. Simple enough, okay? Remember, this is comfort care. It doesn't mean you run in and get an assessment. If they're bonding and holding, then you don't do it. It's okay. Pulse oxes. We are not going to do pulse oxes. Now, if they want a spot check, because it makes them feel more comfortable to see where their baby is at, then do it. But we're not leaving it on. We're not going to put it on at delivery. It's only if the parent requests. Because remember, their heart rates are going to be high. Their oxygen levels are going to be low. It's going to go off, and then everyone's going to freak out. We're not doing anything about it. You can offer blow-by up to 2 liters of oxygen. That is going to be the order. We're not giving 10. We're not giving PPV. And the reason for blow-by, mom's going to be sick and tired of holding it here, and what is she going to do? Drop it. That's what we want. We want them to have an easy passing, and we don't want mom to focus on all this aggressive stuff. That's going to promote this to stay longer, okay? We want normal tactile stimulation at delivery. Clear their mouth, dry them off, do all the normal stuff. Show these parents that we care. Don't be scared of this baby. No shots, no routine, normal newborn stuff. Offer breastfeeding. Again, mom's gonna be all into that. And I mean, really, it's comforting. maybe we won't have to give morphine or Ativan. Breast milk might be enough. And she's not gonna pay attention about what's going on. She's gonna focus on her baby. Also, offer skin to skin as long as possible, whether it's mom or dad. It's gonna help the baby relax. Then, if there is a possible discharge, also remember, we can get them home with hospice, okay? They don't have to stay here to die. But if they are going home, they do need a car bed. We will not send home in a regular car seat, so they'll go home in a car bed. So for comfort measures, non-pharmacological, skin-to-skin, swaddling, holding, pacifier. Our meds right now, as it stands, is gonna be morphine and Ativan. We are looking into working with Wake and Dr. Grodiget and his team, possibly fentanyl intranasal. The dosing is a little bit easier. Suctioning is gonna be limited to a bulb syringe. Just remember, suctioning is uncomfortable. If we don't need to do it, we don't have to, so we wanna decrease agitating the baby as much as possible. So, signs of respiratory distress. And this is where you might think morphine may come into play. Grunting, agonal breathing, head bobbing, retracting, nasal flaring, gasping, stridor, and tachypnea. Now, oh my God, I'm scared to give morphine. What do you say? Mom, do you feel like your baby's uncomfortable? She says no. I don't care how you feel, because a lot of these babies scare the crap out of me. If mom is comfortable, then you don't give it. Just remember, if mom is uncomfortable, you be uncomfortable. You give a med to make mom comfortable. They're dying anyway. These drugs are not going to enhance their death. Okay, these doses are so low, because remember, we're guesstimating the estimated weight from their last ultrasound, which could be 4 or 6 weeks ago. They've grown. So we're so underdosing at that point. So you're never gonna give a dose that might be their last breath. So you're not gonna enhance it, but if she's uncomfortable, then you give it. If she doesn't want it, then you don't give it, even if it looks horrible, okay? Because they have the right to say, don't give it. And then also, that makes your heart feel a little bit better, because what if you did give it and then they passed? And then you're like, oh my God, I just killed their baby. Well, mom asked you to do it, so that kind of helps that little tug on your heartstrings that I did it. Pain-wise, you know, you have your high-pitched crying, your difficulty common, facial grimacing, difficulty feedings, frequent hiccuping, yawning, sneezing, fast or slower breathing, avoiding eye contact. You might have the bugging of the eyes, and then decrease in activity level. Again, mom, do you feel like your baby's in pain? Do you want me to give them something for pain? Yes or no? Yes, give it. No, you don't give it.
If they ask you, well, what do you think? Because that's always a question.
These are the signs that I am seeing. You have to make that decision.
Gotcha.
I see these signs. This indicates to me that your baby's having pain. How do you feel about that? And with Christian, we left that up to mom to decide. Which now, I know morphine has been a big issue trying to figure out. I did get a nice little guide, and you can print it out and post it wherever, that makes dosing morphine a little bit easier. The concentration is 20 milligrams to 1 ml. But again, also remember, so where the Ativan comes in is you've given morphine and it's not working. Sometimes it's more agitation than it is respiratory distress or pain, and so the Ativan actually enhances the morphine. And it's really not the morphine you needed to give, it was the Ativan, but you're always realizing that it's like respiratory distress or pain first that you would assume. So when in doubt, you follow with the Ativan, because it's kind of really hard to tell if a newborn's agitated. You assume that it's respiratory distress or pain. So the other big component with that is social work and chaplain. We have a social work and chaplain available 24/7. So when you get into these situations, If you don't have somebody in-house, you can call us and we can provide you social work and chaplain support. Every patient of ours is assigned a social worker and chaplain. So I know recently we had a patient that needed a priest because they wanted last rites and kind of turned into a hoopla. You can always reach out to us too. You might not need me as the nurse here because we've got all of you wonderful people, but you might need that chaplain or you might need that social worker. We can help you with that because we have someone 24/7. So don't hesitate to reach out to us. We always have one on call, and that is a service that the family signs up for when they sign on to our services. All you have to do is call our triage line, or you have my number, you can call me, and then I can find someone to come in. And they're available 24/7. So now, off the beaten path, like trying to get a priest, because we have mostly non-denominational chaplains, they'll make phone calls to outside agencies or churches, and they'll find somebody. Any questions about that? I know the biggest thing our families have when we put a DNR in place, they're like, is no one gonna care for my baby? You know, that's the biggest thing and the biggest worry for our parents is that no one's just gonna resuscitate their baby after birth and no one's gonna care for my baby, they're just gonna let it lay there until it dies. And I assure them that's not going to happen, and so that's why we said Q2-hour vitals if they allow. And skin to skin and those kinds of things, but really we just love on them, support them, and really just wait for it to happen. But those that come in, we're not looking for days worth of life. Now, if that happens, you know, do we keep them in the hospital or do we start talking about do they go home with hospice? All of our babies, while they're in the hospital, will be palliative care. And then we would decide at that time of discharge whether they go home with hospice or not. And like the one that just delivered, we had mom, but baby wasn't terminal. And everything went well. We didn't pick up baby because baby doesn't need our services. So just because mom's on our service, things went really well, we might not pick up baby. We just saw her through, educated her, provided her everything she needed for after baby's born. So not every baby's gonna be a do not resuscitate and end in a death. And then some babies might move to palliative or hospice depending on where they're at after birth.
Is there a pack of meds that can already be accessible, like, so that we don't have to wait through pharmacy to get, that stays in the pieces?
It's something we'll have to ask for.
So what the paperwork said is we pre-register baby. That's what happened with that one. And then the labor nurse is supposed to take it to the room and lock it in the drawer. It's supposed to be there for delivery.
We
We
have a
find out
process
till
for
after the
those,
fact.
but as far as a kit, we can ask. It's just hard with the dosing, and I don't know how they'll feel about it. But we'll ask.
Because the dosing is based on a kilogram, so if maybe it's the
But the
patient that,
labor nurse will bring it, like, the labor nurse is supposed to, like, the secretary pre-ins it, and we have the orders from Dr. Hada, and then it's supposed to be, like, pharmacy should already have it before baby's born. The labor nurse is supposed to bring it to the room and lock it in the drawer.
Now, Dr. Hada will only be involved in those do not resuscitate cases. Now, if we have a patient that is going to be a full code, that will continue on like any other patient in this hospital where Barry and Wellman will get involved if that's needed. Like we have one coming up, that patient's a full code, it's a Down syndrome baby, and everything else looks normal. If anything's wrong, it'll go to the NICU and all the normal stuff will happen, even though we are involved in that case. So you wouldn't have any of these routine orders. These are only for the do not resuscitate comfort care patients.
So our newborn nursery nurses are not gonna be having to deal with these orders at all?
So what I was showing you is this order set. It's not approved yet. I have to meet with host and they nitpick all the meds and all that. But once it's approved, it will be built into Meditech.
Yeah.
So when we do have a baby, these are the orders that the newborn nursery nurse will enter. It will be built in there just like your conditional newborn admissions. And then all that will trigger the meds and all that. So really, if the baby's pre-registered, you can go ahead and order this, get the meds ordered, and go from there. And you'll just put the weight that's in the chart. How does that look? Does that come across? Do we have the weight already?
So, most of these patients have been with Dr. Grodiget. As long as he's involved, he wants to continue seeing these patients up unless there's a financial burden. He's like, then I will quit seeing them, but if not, he will see them up until the set delivery time. So we will have the best estimated weight.
So we'll look back at the ultrasound, the last ultrasound weight.
And that's what we've used in the past, is that last ultrasound estimated weight.
Will that be like a set, like for the newborn, we just add in, on Meditech, it'll be like. almost
Yeah,
like-
it'll be
okay.
built in there. It's
Okay.
not live, like I haven't even met
Yeah.
yet with the, but once it does go live, I'll let you guys know.
Okay,
It'll just be the same as any other orders that you guys
Okay.
send.
Until then, what we can do is even write all this out as an order from Dr. Hada before they come in. Or if they come in, then we can write it all out and send it over as a signed order from Dr. Hada.
I have that meeting this week, so hopefully this will take another 2 weeks, 2-3 weeks at the most. to get everything.
And if they need any changes, just let us know.
How would they get the weight, how would the newborn nurse get the weight, so that they could dose the meds?
Oh, that's what we were just talking about on the ultrasound, the last
I know, but
ultrasound.
how would we know, I mean, how would we get the ultrasound? You'd pull it out.
so do these babies get reweighed at birth in case there's a big difference?
No, not until after, most likely until after the baby passes. Because if you look on there, you'll actually be able to redose every 15 to 30 minutes. So eventually, it's not gonna matter, because you're gonna continuously give more doses, which in turn, normally you're gonna dose every 1 to 2 hours in general. So every 15 to 30 minutes, you would meet your maximum milligram per kilo anyway. And that's the one thing we were trying to avoid, is taking baby away from the family to weigh.
Now, if they requested it, well, like, hey, how much do they weigh?
Whatever they request, if that's what makes them happy, by all means, we can do whatever they want to do.
We at that time change the weight, or just keep it as?
I mean, you would have to go in and reorder and get Omnimeds from pharmacy, and that can delay the medication. I mean, if you do it, you can keep it to yourself, but, in this situation, like I said, it would delay, because by the time you got the new weight, you would have to get the new order, send it to pharmacy, and wait for them to re-dose, right?
You could probably honestly just send a message to pharmacy, just send a message with updated weight.
But getting that in the computer, like,
But then the
if you're
next one
every
we get.
15, that it would take an hour more for them to get it in there and get.
It probably depends on how much you're off. If somebody has an 18-week ultrasound and you're going by that weight, and then you have a 37-week baby, which probably won't be the norm, but it could happen, then your weight's gonna be substantially different, and it would probably be good if you're seeing a reason to give that medicine, then you probably wanna do an accurate weight.
Which I feel like any of the OBs, if we didn't see fetal medicine or something, and, you know, our last true ultrasound was at like the 18-20 week mark, and they're like 36 weeks or something, I feel like all of them would at least give us an ultrasound for an estimated weight. I don't know that anyone would refuse that, because that's what we did with 2 of the other ones. They just did a weight ultrasound. But, I mean, it could happen.
Do you have any more questions for Daniel? Heartburn?